Hi there, this is Nursing Education Videos. Today I will be reading Blood Transfusion Procedure NCLEX Review on registerednursern.com. All credit for the information that I am reading is from registerednursern.com. Please refer to the websites in the description box for all credit and information. Links for the information will be included in the description box. Blood transfusion NCLEX review for nurses. As a nurse, you must know how to transfuse blood and what type of transfusion reactions can happen during a blood transfusion. Don't forget to take the blood transfusion NCLEX quiz after reading this review. Blood transfusion NCLEX review. What is a blood transfusion? It's where the nurse transfuses a patient with new red blood cells via a venous access. Most transfused red blood cells are from donated red blood cells. Why would a patient need a blood transfusion? Because the patient is low on red blood cells, RBCs, or erythrocytes. A few reasons why a patient may be low on red blood cells would be anemia, so the body not producing enough red blood cells, or the body is destroying them. Some examples of these cases for anemia is renal failure, cancers, liver failure, etc., as well as excessive blood loss due to surgery or trauma. What is the importance of red blood cells? Our body can't function without them very well. When a patient is low on red blood cells, they may experience pale-looking skin color, feeling weak, experiences shortness of breath with activity, tachycardia, where the heart has to work harder to replenish the organs with oxygen, etc. Red blood cells red blood cells, with the help of the protein hemoglobin carries oxygen. It receives from the lungs throughout our body and helps remove the carbon dioxide that has collected in our body, which will go to the lungs to be exhaled. When are patients usually transfused with red blood cells? It depends on what is going on with the patient's health history, their current signs and symptoms, etc. But recent guidelines by the American Association of Blood Banks recommends transfusing blood when hemoglobin falls between 7 to 8 grams per deciliter. This is due to the guidelines define hemoglobin levels for transfusion 2012. What are normal hemoglobin levels? Varies depending on gender. Men 14 to 18 grams per deciliter. Women 12 to 16 grams per deciliter. The nurse's responsibilities with blood transfusions. Transfusing blood is very common in the hospital setting. Most hospitals only allow registered nurses to transfuse blood. As a new graduate, be sure to access your hospital's protocol for transfusing blood and be familiar with their rules. Prep work. A lot of prep work is done before a patient is transfused with packed red blood cells to prevent a transfusion reaction. One of the most common reasons for a transfusion reaction is a clerical error, so the prep work is very important. You receive an order. Transfuse patient with 2 units of PRBCs, which are packed red blood cells. 1 unit is transfused at a time. First, the patient will be typed and cross-matched. This will require you to draw blood and place a blood band on the patient. Note, it is very important everything is written correctly. If any errors occur, this would increase the risk of a transfusion reaction. Then, send the blood to the lab, who will type the patient and cross-match it with the donor. Then the prescribed amount of units will be ordered. The blood bank will notify you when the blood is ready. As a nurse, you must be familiar with the ABO blood types and compatibility along with the Rh factors. Rh positive can receive both Rh positive and negative factor blood, while Rh negative can only receive negative factor blood. Be sure to watch Registered Nurse RN's blood typing lecture on this topic. Quick review. O type is a universal donor. AB type is a universal recipient. Obtaining informed consent. Assess your patient's allergies and their understanding about a blood transfusion, the purpose of the transfusion, how it is performed, and what signs and symptoms they must report to the nurse if they experience them during the transfusion. Also, this is a great time to ask them if they've ever had a blood transfusion before and if they tolerated it well. Let the physician know if the patient had a transfusion reaction before or has received many blood transfusions in the past. The physician may need to order the patient to be pre-medicated before the transfusion. Why? If a patient has received many blood transfusions in the past, they create antibodies that can lead to a febrile non-hemolytic transfusion reaction, which is the most common type of transfusion reaction. More information about this below. Pre-medications used: Benadryl, which is diphenhydramine, and Tylenol, which is acetaminophen. If ordered orally, give 30 minutes before transfusion. In addition, if the patient is at risk for circulatory overload, like patients with heart failure, etc., a loop diuretic called Lasix or furosemide may be ordered before, after, or in between units. Need IV access. Follow hospital's protocol. 18 gauge or larger. Why? To prevent damage to the transfusing RBCs. The RBCs, which is red blood cells, will lysis if the cannula is too small. Note: if the patient will need IV medications at other times while the blood is transfusing, the patient will need another IV access site, so keep that in mind. The IV line transfusing the blood is just for the blood administration during that time. No other medications or fluids. Supplies needed: special wide tubing that has an inline filter, a bag of 0.9% normal saline. No other fluids can be given with blood or hung with it ever. Other fluids like dextrose fluid can cause clumping of the blood cells. The normal saline is used to prime the line and flush it afterwards. Other supplies to dispose, which is a red biohazard bag. The blood bag and tubing never goes in the regular trash can. Follow hospital protocol for how often to change the wide tubing. Some say to change wide tubing sets after each unit, while others say that the set must be changed after 4 hours. Remember, each unit must be given within 2 to 4 hours from the time it leaves the fridge. So if you're giving 2 units, you may go over the 4-hour limit if you run it slowly. So each unit given within 2 to 4 hours. So if it's 2 units, it would be a total of 8 hours if necessary. Transfusing the blood. When the lab notifies you that the blood is ready, you will let them know when you are ready for it. Either you will collect the blood yourself or someone will bring it to you. You must start the transfusion within 30 minutes of receiving the unit of blood. 1 unit is given at a time. Notify the blood bank to send the blood when you're ready for it. 30 minutes goes by fast as a nurse. Blood warmers can be used when giving large amounts of blood quickly and for patients who may have a hypothermic response. Use a special warmer for warming blood. Don't warm it up in the microwave. Before starting the transfusion, a verification process is done. You will verify everything is correct with another registered nurse. We'll do this with each unit of blood. And then hospitals vary on who you do this verification with. It usually needs to be licensed personnel though. Most require 2 RNs to do this. So before starting the transfusion, a verification process is done to match the correct patient with the correct RBCs, so red blood cells. What is verified? You verify the order, the patient's identification and blood bank's information, the patient's blood type and donor type and RH factor if it's compatible, the expiration date. Look at the blood, make sure it doesn't have any clots or abnormal substances in the blood or it's damaged. Everything must match. If there is a discrepancy, notify the blood bank immediately. Don't start the transfusion. Baseline vital signs: blood pressure, heart rate, temperature, and respirations. If temperature is greater than 100 Fahrenheit, notify MD. Again, explain to the patient about what is about to happen and inform the patient to notify you immediately if they start to experience the following: sweating, chills, chest pain, shortness of breath, headache, back pain, nausea, vomiting, and itching. Start the transfusion slowly on an infusion pump, 2 milliliters per minute, which is the same as 120 milliliters per hour for the first 15 minutes. And stay at the patient's bedside for the first 15 minutes. If the blood is tolerated after 15 minutes, rate can be increased. Most blood bags are 250 to 300 cc's, which is 250 to 300 milliliters, and remember they must transfuse within no more than 4 hours. Why? Most transfusion reactions occur within 15 minutes. So within this time frame, and you want to give the least amount of blood to minimize that reaction if the patient is going to have one. Obtain vital signs per protocol. Most transfusion bags come with a piece of paper where you record the vital signs and it will go in the patient's chart, but again, this depends on your hospital system. You will obtain vital signs at 5 minutes from the start of the 5 minutes, and then 15 minutes, then 30 minutes, 1 hourly until done, and then 1 hour after transfusion. So you obtain a set of vital signs 5 minutes after the start of the transfusion, and then 15 minutes, and then 30 minutes, and then every hour, and then 1 hour after the transfusion. Watch for various types of transfusion reactions. Immune system interacts with the donor's blood, such as allergic, hemolytic, febrile, GVHD, which is graft versus host disease, along with other complications like circulatory overload, especially in patients who are susceptible to this, like cardiac and renal patients. Acronym: reaction. R for rash, which are hives. E for elevated temperature, 1 degree Celsius or 1.8 Fahrenheit or more from baseline. A is for aching, back, chest, or head. C is for chills. T is for tachycardia. I is for increased respirations. O is for oliguric. Oliguric is low urine output or no urine output, which is anuria. Hemoglobin urea, which is free hemoglobin in the urine, which is a purplish color. And then nausea, which is diarrhea. Oh, nausea. I'm not sure why, but it's written here: nausea, bracket, diarrhea, bracket. Flush the line with normal saline and dispose of it properly when the blood is done transfusion. Then obtain vital signs 1 hour after transfusion. Review of transfusion reactions. Hemolytic. So this is where the immune system is killing the donor's RBCs. The antibodies in the recipient's blood match the antigens on the donor's. The antibodies in the recipient's blood don't match the antigens on the blood donor cells, which is mistyped. It's written on the website, the antibodies in the recipient's blood matches the antigens on the donor's blood cells, which I don't think is correct. Hemolytic reactions happen because the immune system is killing the donor's red blood cells. It's because the antibodies in the recipient's blood don't match the antigens on the blood that is being donated to them. So this is a mistyped. This could lead to disseminated intravascular coagulation and renal failure, which could result in death. Symptoms of this is fever, chills, anxiety, back pain, chest pain, hemoglobin urea, increased heart rate, and low blood pressure. An allergic response is where the recipient's immune system reacts to the proteins found in the donor, can progress to anaphylaxis. Symptoms are hives, rashes, respiratory issues, wheezes, oral swelling, anaphylaxis reaction. Febrile, which is non-hemolytic. The recipient's WBCs, which are white blood cells, are reacting with the donor's white blood cells. This causes the body to build antibodies. You can see an increase in temperature 1 Celsius or 1.8 Fahrenheit from baseline. Most common, especially if patient has received blood in the past, because their body has created antibodies. So symptoms of this is chills, headaches, increased heart rate, and fever. So GVHD, which is graft versus host disease, rare but deadly and occurs days to weeks after the transfusion. The donor's T lymphocytes causes an immune response in the recipient by engrafting in the marrow of the recipient and attacking the recipient's tissues. These T cells are usually killed by the recipient's body, but not in this case. Bracket suppressed immune system. Bracket. Symptoms of this is fever, rash all over the body, feet and hands as well, GI issues such as diarrhea, nausea, and liver inflammation. Other complications, not immune related. Septicemia, blood is contaminated. Very important to start transfusion promptly after receiving the blood, and that it is done transfusing within 4 hours. So septicemia, which could be due to the blood itself being contaminated before the transfusion. So that is why it's very important to start the transfusion promptly after receiving the blood from the blood bank and that it is done transfusing within 4 hours. Blood is contaminated with a disease, so bracket not as common due to strict screening guidelines, though the blood could be contaminated with hepatitis B, hepatitis C, or HIV, etc. Another complication would be circulatory overload or high iron risk, which is due to frequent blood transfusions in the past. What to do if a transfusion reaction happens? You stop the transfusion and note the time mentally when the patient started showing signs and symptoms of a reaction. Disconnect blood tubing from IV site and replace with new IV tubing set up at the IV site, and keep vein open with normal saline, 0.9%. Bracket limits any more blood from the transfusion entering the patient's blood. So when you disconnect the blood tubing and you replace it with a new IV tubing set, it would limit any more blood from entering the patient's bloodstream. Notify prescribing physician and blood bank. Do all this while staying with the patient and get help from other staff. And then monitoring vital signs every 5 minutes. Based on patients' reactions and their signs and symptoms, you will be ordered to give them various medications such as corticosteroids, which suppresses the immune system, fluids, which flushes the kidneys of the hemoglobin, antihistamines, decreases the immune response, antipyretics, which decreases the temperature, vasopressors, which increases blood flow to the kidneys or open airway, allergic reaction medications such as epinephrine, or diuretics to cause more urination. So vasopressors also increase blood pressure. Labs will be ordered for blood work such as clotting levels, which could be the DIC, which is let's prescribe. Which stands for disseminated intravascular coagulation. Disseminated intravascular coagulation. Disseminated intravascular coagulation. There we go. And electrolytes. So labs will be ordered for blood work, clotting levels, to look at disseminated intravascular coagulation, electrolytes, blood levels, renal function, etc., along with a urine collection for hemoglobin urea. Keep and bag up blood bag and tubing and other documentation and set it to the blood bank. They will let you know what you need to send. Don't throw anything away. It will be tested and analyzed for what went wrong. Document. Include time it was noted, the actions you took, and currently how the patient is doing. The references for this information is Basics, Blood Safety, CDC, cdc.gov, retrieved on 13 March 2018 from www.cdc.gov/bloodsafety/basics.html. And the next reference is Guidelines Define Hemoglobin Levels for Transfusion 2012. Medscape. Retrieved 14 March 2018 from www.medscape.com/view article/7609119. I hope this information was helpful and engaging, and I hope everyone have a great day.